Dear colleagues, welcome to today's Heart Failure Association webinar on a practical approach to diuretic use in heart failure. I am Professor Alex Mebaza from University Hospital Saint-Louis-Lariboisière, and I have the pleasure of being joined by two friends and heart failure experts, Professor Wilfried Mullens from Ziekenhuis Oost-Limburg, Genk, Belgium, and Dr. Kevin Daman from the University Medical Centers of Groningen, Netherlands. The aim of this webinar is to give you a better understanding of the management of heart failure. Diuretics are the most frequent therapy administered to our heart failure patients. We will learn how to best optimize the use of diuretics in heart failure. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentations. This program is supported by Heart Failure Association. I will now hand over to Professor Wilfried Mullens for his presentation.
Thank you, Alex. Good evening, everybody. So my case is about how to use diuretics. These are my disclosures. I'm a heart failure specialist. I like to think physiologically, and I do actively investigate the kidney, and I'll try to explain how we can improve the management of patients with congestion. First of all, we need to emphasize that there is an underestimation of risk for our patients to be hospitalized or to die. In a chronic stable heart failure patient, there's about a 20% risk at 2 years for that patient to die or to be hospitalized with heart failure. And this comes from the Paradigm study examining sacubitril valsartan. In acute heart failure, that risk goes up to 60% at 1 year, especially if we send our patients home still with ongoing congestion. So congestion will be the key target for acute heart failure therapies. Congestion actually hampers end organ dysfunction, and especially the kidneys. If you have an elevated central venous pressure, the natriuretic response to any diuretic therapy will be reduced in acute heart failure. The problem, therefore, is diuretic resistance. Diuretic resistance is basically omnipresent in heart failure patients. If you would infuse 40 milligrams of furosemide to a normal patient without heart failure, he would pee out about 3 liters of volume within the next 6 hours. If you have heart failure and you are already on a loop diuretic, that response will be extremely reduced. That's why we come to this first case. This is a 75-year-old male who was diagnosed with heart failure with reduced ejection fraction based on a non-ischemic cardiomyopathy in 2016. His hemoglobin at that point was 12, his potassium was 4.8, sodium 134, and his creatinine is 1.5, making up for an estimated GFR of 50. He was medically treated with candesartan, basoprolol, and spironolactone. He was not on an ACE inhibition because of a cough. His ejection fraction actually improved from 30 to 45%, which is something that we often see with good medical therapy in HFrEF patients. From 2016 to 2018, he was basically doing fine. We saw a small increase in his QRS rate to 135 milliseconds, but clinically he was doing fine, and his ejection fraction stabilized at 45%. And then at February 20th of 2019, he actually went to his general practitioner because he was progressively dyspneic, also had some edema in the legs after an upper airway infection. The general practitioner actually drew some bloods, and his NT-proBNP was elevated to 5,500, and he treated the patient medically with bumetanide 1 milligram orally, and he kept the rest of his medications similar. Then on February the 23rd, he entered to the emergency room. That was a Saturday at 5 p.m. with more signs of volume overload and also more dyspnea. His blood pressure was 145/84. He was in sinus tachycardia. He had clearly elevated central venous pressure and a positive hepatojugular reflux. Had a systolic murmur at the apex, diminished breath sounds, and edema up to the knee. To actually point how you have to investigate edema, you have to push on the zone of the edema, and then you see this dwelling of the skin. When we draw a lab test, you could see that this BNP was even higher now. It was up to 8,500. His creatinine was increased to 1.8. It was 1.5 a couple of days earlier. Sodium and potassium were still pretty much okay. His echocardiogram showed a ejection fraction of 25%, significant secondary mitral regurgitation, diastolic dysfunction grade 3, and elevated pulmonary pressures. He had some cardiomegaly and bilateral pleural effusion on the chest X-ray. So the first question will be, what would be your preferred loop diuretic strategy? You could either double the dose of the loop diuretic orally, so he was on 1 milligram at home, so you could give him 2 milligrams. You could give him a bolus IV of bimetanide of 1 milligram, bolus IV 2 milligram, a continuous IV loop diuretic without a bolus, continuous IV loop diuretic with a bolus, or an IV diuretic plus a low-dose dopamine.
Thank you. While we are getting the answers, Wilfried, in your center, do you have an algorithm for the use of loop diuretics in the first minutes when a patient is coming with acute heart failure and having so much edema?
Yeah, we actually train our fellows and our registrars how to take care of these patients, and the early assessment of the congestion is really important, and also the early recognition of the congestion. It's also important to emphasize that this is a typical patient. He comes into the emergency room with signs of symptoms of volume overload and pretty high blood pressure. We rarely see patients with a low blood pressure, so most of them have a high blood pressure when they enter the hospital. Also important is that the fellows or the treating physicians search for a precipitant factor. Most of the time there's something going on that actually triggers the heart failure, and in this case it was an upper airway infection.
And to come back to your question, people like combination. The favorite answer is answer number 5. Mm-hmm. Then people liked the continuous IV loop diuretics with bolus.
Mm-hmm. Okay, that might be one of the options, but let's look at the data. So the data that we have come from the guidelines, and the guidelines actually tell us to use IV loop diuretics in patients with acute heart failure with signs and symptoms of fluid overload. And they actually suggest to use about 40 milligrams of IV furosemide for patients who are not on a loop diuretic therapy. They don't really emphasize how you should do the follow-up. What about the studies? There's only basically one study that actually examined the effect of loop diuretics in patients with acute heart failure and volume overload, and it was the DOSE trial. It compared a low dose versus a high dose, continuous versus bolus infusion of loop diuretic therapy, and there were basically 4 arms. Actually, the results were pretty negative. At 2 months of follow-up, half of these patients actually died or were hospitalized back for heart failure. What was even more worrying, that only 15% of the patients treated with one of these 4 strategies was actually deemed to be dry after 72 hours of therapy, suggesting that the way that loop diuretic therapy was administered in the DOSE trial was less than optimal. That's why there's this new concept of door to diuretic time, meaning that you should act really early on when you have a patient with congestion and volume overload. As you could see in the right panel, the door to furosemide time actually is important. As soon as the patient enters the hospital and he is volume overloaded, you should give a loop diuretic agent, and the prognosis will be better. The prognosis will be better independent of the severity of your heart failure patient. What's also important is that based on these new insights, that the HFA put out this paper which basically helps you to guide the utilization of diuretics in heart failure patients. The first step here is to actually detect the patient with congestion and volume overload, and then to assess if that patient already was on a loop diuretic. If he was not on a loop diuretic, you can just start with giving 40 milligrams of furosemide or 1 milligram of bimetanide intravenously. If he already was on a loop diuretic, you should at least give that dose, but preferably give the double amount of the dose. So in this particular patient, you should have administered 2 milligrams of bimetanide IV as a bolus infusion. Also important to emphasize already at this stage is that you have to ask the patient to empty the bladder before you administer the loop diuretic in order to assess the effectiveness of the diuretic agent. The next question is, this patient came in at 5 p.m. on a Saturday evening. He was congested. He got diuretics. How and when are you going to evaluate that patient again? Clinically, the next morning, or you're going to just look at the urinary output the next morning. You do a clinical exam and you look at the urinary output. You combine it with a lab test or even an echocardiogram, or you do something else.
Thank you, Wilfried. Urine output is mentioned several times in your answers, and probably it's an important point. How in your center, how would you manage, because we have old patients, we have patients that are very sick, less sick, etc. How would you manage the measurement of urine output?
Yeah. It's an important topic, of course, because you're going to administer a loop diuretic and you want to measure the effect of the loop diuretic. If you would compare it with placing a stent, you're also going to measure if the stent is open, if there's patency of the vessel. So you need to assess the effectiveness of the diuretic agent. So measuring urinary output is really important. It depends also on the volume or the amount of volume which is there in that patient. But if your patient is deemed urinary incontinent, we easily place a Foley catheter, especially if we expect that patient to have a lot of volume outputs within the next couple of hours.
Then the answers, at least the most favorite answers, were 4 and 5.
4 and 5. Might be good answers, but we think you need to do something else, because there are two things that we need to emphasize here which might be novel for some of the audience. First of all, you have to early evaluate within hours the effect of the diuretic. The loop diuretic works for 6 hours. It doesn't work for 12 hours. So if you're going to wait until the next morning, you lose that window of opportunity to treat that patient better during the night. Secondly, you have to reassess the congestion and the volume status 6 hours after that patient was being admitted into hospital. And it's either you or the nurse who can actually do that. Let's go a little bit more in detail. First of all, congestion doesn't mean volume overload. There's congestion, that is a hemodynamic definition of increased filling pressures, and that can be accommodated with fluid overload or not fluid overload. The typical HFpEF patient doing fine at home goes in AFib, then develops pulmonary congestion. That's not so much volume overload as our patient with HFrEF with a protected cause of volume overload. Secondly, the assessment of congestion is not easy. There is nobody who has the wholly single parameter to actually predict what congestion is. So you have to do a comprehensive assessment, including a clinical exam, but also some technical exams, and that can be a chest X-ray, an ultrasound of the vena cava, for example, and NT-proBNP measurements. NT-proBNP measurements are really important to actually detect congestion. They're less important during the first days to guide your decongestive therapy, as it takes a couple of days before they're actually going to change. Of course, it's more important to have a lower BNP at discharge than a higher BNP, but you cannot really use them from a daily basis to actually guide your decongestive strategies. And then what to do, how to assess the diuretic effectiveness. So what you need to do is an early evaluation. So you give the diuretic, and within the first hours you have to look at the response of the diuretic treatment. You can do that by two measurements. First of all, you can measure the urinary output, and a decent diuretic response will mean at least 100 mL urinary output per hour during the first 6 hours. Also important is to measure the sodium, what is going to come out. We know that if you have more than 50 mg sodium per liter coming out, that's a good diuretic response. So you either instruct your nurse to measure the urinary volume, and if that's enough, more than 100 mL per hour, that's fine. But if that's less than 100, or if that's reaching 100, you also have to do something else, and that's measuring the sodium, what is going to come out. If your patient doesn't have a Foley catheter, you measure the first void of urine after you administrate the loop diuretic, you send it to the lab, within an hour you get the result, and that will help you to guide further diuretic therapy. Because if that patient is still volume overload and he had a good diuretic response after your first diuretic administration, you just repeat a similar dose. If that patient had an insufficient diuretic response, defined by a urinary output of less than 100 mL per hour or less than 50 mg per liter for sodium, then you double the dose of the IV loop diuretics. And you keep on doing that algorithm until you reach the maximum IV daily dose, which is about 10 to 15 milligrams of bumetanide in our patient population. For the rest, you also do some parallel intervention evaluations. That's just a standard non-invasive monitoring of heart rate. You don't need an A-line in all of the patients. And very importantly, you continue the guideline-directed medical therapy, including the ACE, the beta blocker, and the spironolactone in patients who are admitted with this type of phenomena. Importantly, why do we emphasize sodium? Because sodium loss predicts survival a lot more than fluid loss. These are data from Jeff Destani, really showing that if you have a positive sodium balance during your hospitalization, then your prognosis is worse, even if you have a negative urinary balance. So meaning if you pee out a lot of water, but not a lot of sodium, then your prognosis is not good. So we need to get the sodium out. Other studies also emphasize the importance of measuring the sodium per milligram brimetanide. If you pee out a lot of sodium per milligram of the loop diuretics, your prognosis is a lot better. Important also in that aspect is that the first 24 hours are crucial, because in the first 24 hours that will be the time frame where you get the most sodium out, because every consecutive day of diuretic therapy will lead to less sodium output, basically the same amount of volume but less sodium. So the quality of the urine is changing day by day, limiting the sodium excretion from day 2 and to day 3. Then the final question, what do you do if you have an inefficient diuretic response? And diuretic resistance is defined as an impaired sensitivity to diuretics, resulting in reduced natriuresis and diuresing, which will limit the possibility to achieve euvolemia. So what do you do if you have that? Keep on doubling the loop diuretic dose, add a thiazide, add acetazolamide, Spiro, a low-dose dopamine, or ultrafiltration.
Thank you, Wilfried. While waiting for the answers, we got several answers on torsemide. I didn't see it in your list.
Mm-hmm. Yeah, torsemide is also a loop diuretic, so that is on the loop diuretic dose. Unfortunately, we don't have the IV administration of it, so we didn't put it in there, because if you give an oral loop diuretic to such a patient, the GI absorption will be significantly reduced because of the bowel edema. So we suggest to not use torsemide in the acute phase because of poor oral absorption.
Then the two favorite answers to your questions are the answer 2, thiazide, and the answer 4, spironolactone. Both got close to 30%, 30 and 30%.
Yeah. It's already good that people didn't vote for answer 5, because that is something that we often see in hospitals happening.
Well, I can still tell you there were 16%, 16 for dopamine.
Yeah, let me first emphasize that there is basically no room for dopamine in this patient. I mean, there is overutilization of inotropic agents in such patients. It is always in every study associated with an increased mortality, so don't use inotropic agents in such a patient and reserve them for patients who are in low output heart failure. So what to do on the next day if you did not have enough urinary output? If you have enough urinary output, meaning more than 3 to 4 liters the first 24 hours, and you still have volume overload, you just continue your current regimen. If you don't have enough urinary output, we suggest to continue to up-titrate the loop diuretics until you reach the maximum dose. And that's 10 to 50 milligrams of brimetanide per day, or 400 to 600 milligrams of furosemide per day. If you don't have enough output with those maximum doses of loop diuretics, then you can add something else. The first line agent might be a thiazide. Importantly, with the thiazides, there are no randomized trials suggesting any benefits of thiazides. And when you use thiazides, you have to think that these drugs take some time before they actually are effective, because they are very slowly absorbed in the gut. So basically, if you want to give a thiazide, you should actually give it more than 6 hours before you give your IV loop diuretics in order to be effective. Also, thiazides are linked to more hypokalemia, and independent of the hypokalemia, there is a signal of harm, of worse outcomes in patients who are actually administered with thiazides. The second line agents might be agents that are working more proximal in the kidney, and that is acetazolamide. It's a very old drug that works proximal in the kidney. It's 500 milligrams IV as a bolus on top of the loop diuretics, and it actually we think, or we suggest, that it will help boost natriuresis. Third line agents might be the SGLT2 inhibitors, but there are no data yet to support that in daily clinical practice. Very importantly, if you achieve complete decongestion, you have to evaluate and prepare the discharge. So we want to send the patient home at the lowest possible dose of the loop diuretic. We have to include them in a multidisciplinary disease modifying program. We have to increase the dose of the neurohormonal blockers, and we have to really schedule a follow-up for this particular patient. What might be the future diuretic strategies for our patients? Of course, less sodium intake. There's a lot of discussion about restriction of sodium intake, and hopefully this study will actually help us to solve that question. And then when we look at the nephron, there are different parts in the nephron. So there's actually very exciting studies going on in the proximal part of the proximal part of the kidney. That's the study with SGLT2 inhibition, but also a study going on with acetazolamide. There is this study going on comparing torsemide with furosemide, so two different loop diuretics orally for patients with heart failure. And then there is one study now actually going on in the States comparing metolazone versus lanreotide for acute decompensated heart failure. So what happened to our patients? When we come back to the patient, he was admitted at 5 p.m. on a Saturday evening. He was administered bumetanide, 2 milligrams as a bolus. He got a Foley catheter. At 7 p.m., the nurse actually took the first amount of sodium. She analyzed it. It was 90 millimegs per liter. It's more than 50. And at 11 p.m., 6 hours later, he already diuresed 2.6 liters, meaning 430 cc's per hour. So he was doing fine. He still had congestion, so we give the same amount of bumetanide, 2 milligrams, at 11 p.m. We did not wait until 8 a.m. the next morning to not lose that window of opportunity to treat that patient. The next morning he had an additional 2.2 liters of urinary output. His creatinine improved a little bit. His blood pressure was still fine. Still ongoing congestion. We again gave bumetanide, and we continued the neurohormonal blockers and increased the Spiro because he had a little bit of hypokalemia. The next day, no residual congestion anymore. Creatinine improved, and also injection fraction improved. Also something that we often see. If you take away the congestion, the cardiac function will improve. And then, of course, we have to prepare the discharge. The discharge note for the general practitioner, including in a multidisciplinary cardiac rehabilitation program, heart failure education. We consider this patient to be a candidate for CRTD if his ejection fraction remains 35%, and we specifically send out a letter to the general practitioner. We often call the general practitioner to inform him that that patient is going to come back home. So these are my final conclusion slides. We think it's very important that we change the way we're treating diuretics, we're using diuretics. We have to early evaluate within hours the effect of the diuretic that we have administered. We have to reassess congestion and volume after 6 hours again, because that's the time frame when the loop diuretic has weaned off. And for chronic prevention, we need to up-titrate the neurohormonal blockers, we need to treat comorbidities, and we need to include those patients in a multidisciplinary disease management program. Thank you.
Thank you very much, Wilfried. We have questions on the management of diuretics at home. Then we understood that, looking on your case, that the patient had a big dose of loop diuretics because he came with a lot of edema. Then we had to really transiently give a high dose. We saw that just before going home, before being discharged, you reduce the dose. Can you tell us when would you see, or when the general practitioner would see the patient? And at home, some of the questions are, but you know, the patient's used to manage his diuretic dose by himself. How would you manage the first weeks, and how would you manage the interaction with the patients to tell him or not how to handle the diuretics?
So the guidelines advise, and that's also what we advise with this cardiorenal committee, to use the lowest amount of loop diuretic possible to achieve euvolemia at home. So we need to use the loop diuretics as a breakthrough drug in the hospitalization in a higher dose, and then reduce it again in order to give room to increase the dose of the neurohormonal blockers. It's the neurohormonal blockers and the HFrEF that will make the difference at the end of the day. It's not the loop diuretics. There are data emerging that the inappropriately high dose of loop diuretics hamper the up-titration of neurohormonal blockers. So it's better to send them home with higher doses of neurohormonal blockers and a lower dose of loop diuretics. Of course, what we're doing is we send them home with a really low dose of loop diuretics, and we see the patient back with the general practitioner after a couple of weeks, within the first week. There is also a possibility that you will send this patient home with a higher dose of loop diuretics, but then you really are enforced that somebody looks at that patient within the next week in order to try to reduce again the dose of the loop diuretic. But the main message is loop diuretics are temporarily increased. That's also what the studies have shown us. The study Champion, which basically looked at the implantable hemodynamic monitor in the US, they also saw that when the physicians were looking at the pressures, they increased the dosages of the diuretics temporarily, and then they weaned it off again, and that gave them room to increase the neuromonal blockers, and that particular approach actually led to an improved outcome.
We got many questions on the measurement of the urine sodium within 4 to 6 hours. Then some people like it, some people say it's not realistic in the middle of the night, etc. Can you re-explain how should we do it?
Yeah.
I mean, we all have patients, we all have nurses, we all have biochemical lab, and we have all patients with acute heart failure heavily congested. Then how would you see urine output, measuring sodium? Why do we do it? How can it help the patient?
So the algorithm is really specific how you can do that. So I would really urge the people to actually have a look at it. But in practice, you have to assess the urinary output first, and that is very easily done, and that can be done by the nurse. Normally, within the first day, urinary output tracks really well with natriuresis. So if you have a urinary output of more than 100 cc's per hour, let's assume it's like 200, in this case it was even 400, there is really no need to measure the sodium output. Because
and if the first 2 hours we have more than 200 milliliter in the first 2 hours?
It's probably not necessary, because you're still going to have more than 600 after the first 6 hours. Okay. But let's assume you would have 150 cc's the first 2 hours, that would be the moment to measure the sodium. If that sodium is also low, let's say 30, 40 megs per liter, then you know that he will not get sufficient output within the first 6 hours, and then you have to change your therapy after 6 hours.
Wilfried, in your center, in your experience, how many patients would have more than 200 milliliter in the 2 first hours, and how many would have less and then would need to go to the sodium excretion measurement?
It depends, of course, on the patient sitting in front of us. It depends on his underlying renal function, on the degree of congestion, and already on his background therapy. If this is a patient with no diuretic utilization at home, who's really volume overload with a normal renal function, you hardly see it. Right. If he is a patient with CKD, already on 5 milligrams of metanol at home, you have a chance of about 30% to see this.
Then what we are speaking here, we are saying that the large majority will react properly to diuretics, high urine output.
Yes.
On
the premise that you look at it.
Indeed.
But if you don't look at it and you wait until the next morning, then you lose a lot of time, and then you have a high chance that patient will not be dry after 3 days of consecutive therapy.
Then so really the message is like you said, stent earlier, I can say vasodilators. When you give a vasodilators, you immediately see whether the blood pressure is down. Yeah. And what you are saying here is exactly the same line of thought.
Exactly.
Give diuretics, and within 1-2 hours, you should see whether urine output is adequate or not. I have many questions on beta blocker. And people are saying your patient comes with, he's heavily congested. We are going to give him diuretics. What would be your first reaction with beta blocker? Would you keep the beta blocker at the same dose, or would you stop the beta blocker? And apparently, many of our colleagues are saying, I would stop the beta blocker. What would you do?
We will not stop the beta blocker, definitely. The biggest threat for our acute heart failure patients during hospitalization is the reduction in neuromonal blockers. We often see, and it comes back in all registries and all epidemiological studies, that we reduce the dosages of the neuromonal blockers, and these patients do worse in the end. So you cannot reduce, or you should not reduce the dose of the beta blockers. There are even our data supporting that if you give more ACE, more beta blockers, you have an increased natriuresis, because it blocks also the sympathetic drive. It blocks the sodium reabsorption in the kidney. So don't stop the beta blockers, don't reduce it.
Thank you.
Of course, don't increase it if you have a low output state, but in this case, you just continue.
Right. Thank you so much, Wilfried. Now we are going to move on to Kevin Daman's presentation. Thank you, Kevin.
Well, thank you, Alex. So the next case will probably touch upon some things we already discussed, and we will primarily focus on renal function, because that's sometimes a difficulty when treating these patients with acute heart failure. These are my disclosures for the current presentations. So this is we could say typical patient that nowadays comes to the emergency department with acute dyspnea. As an 80-year-old male. He is already known to the cardiologist with an NSTEMI in 2005, having PCI, He's had a cabbage and then AVR in 2009, and in 2015 he was in NYH class 2. He had normal LV function, probably some diastolic dysfunction, and he had grade 2 out of 3 mitral and tricuspid regurgitation. If you look at his medical therapy, I think that's what you would expect. He has low-dose ACE, beta blocker. He is on furosemide, 40 milligrams once daily, and he has nitrosublingual for his angina. So when we talk to the patient, he tells us that in the past 2 weeks he was already dyspneic and he had signs of a sinusitis, and this is the reason to go to the general practitioner, and he was prescribed antibiotics. And the night before he was eventually admitted at our hospital, he had acute worsening of his dyspnea. And next to that, he couldn't lay flat, he had autopnea, he had actually no reasonable weight gain in the past 2 weeks, and he had more edema than normal, so probably had edema in the years before. So what Wilfried touched upon, this guy is hypertensive, 160/80. He has atrial fibrillation, what was new for him. His O2 stat is 94%. He's autopneic, his GVP is elevated, and he has RALs, and he has edema up to his knees. So he is definitely congested. So we do some additional investigations to clearly make next decision on therapy, and you see his chest X-ray. What you can make out of it is enlarged heart and redistribution. And his lab, he has normal hemoglobin. His sodium is 142, potassium 4. His creatinine is around 1 milligrams per deciliter, which translates to 88 micromole per liter. And if you calculate his eGFR, even for this 80-year-old guy, it's 72, so it's relatively preserved. You see some troponin release, which we often see in acute heart failure, and his NT-pro is above 2000. His EKG shows you atrial fibrillation with a heart rate of about 90. So our working diagnosis when admitting this patient, seeing him on the emergency department, was acute heart failure. Could be a viral upper respiratory tract infection as a trigger, and together with atrial fibrillation, which was de novo for this patient. So you've already heard what our thinking is on how to treat this patient, and you've seen the algorithm, and I will briefly point towards the note that is added to it. You see that this patient was not naive to furosemide, so you could start with the double oral furosemide dose IV. If the patient is naive, you give 20 to 40 milligrams furosemide. What I want to emphasize is that if a patient has a low eGFR, you need to dose a little bit higher. And the reason for this is that the loop diuretics need to be secreted into the tubule to get to their site of action. And in heart failure, we know there's probably a low flow state, there is high central venous pressure, and in those circumstances, the secretion of loop diuretics is decreased. So in this patient, to remind you, he was on oral furosemide, 40 milligrams once daily, and he had a preserved eGFR at admission. So what typically happens in the Netherlands, already the ambulance started furosemide, in this case 40 milligrams IV, and we started him on the emergency department with a bolus infusion of another milligram. So this calculates together to about 2 milligrams of bumetanide together with the 40 milligrams of furosemide, which means you give a bolus. And this is important because our current treatment regimen in our institution that we follow by a bumetanide perfuser, in this case 5 milligrams per day. So it's important to give a bolus before you start the continuous infusion because you want to reach good levels of bumetanide. So we touched upon evaluating the diuretic response. In this case, in the first 6 hours, we had a diuretic response of more than 100 milliliters per hour, which was 1200 in the first 6 hours. And just to give you an idea, in this case, we had urinary sodium in that urine of almost 120 millimoles per liter. So going forward, because it was a good responder, the diuresis in the first day was above 3 liters. Creatinine was stable at that point, and actually his NT-pro increased a little bit further, and he had residual signs of congestion. So this is the first question. If you're going to think of how this patient will be doing in the next days in hospital, what change do you typically would expect in a patient, or actually would be happy to see in a patient treated for acute heart failure with diuretics? Would you want to see a decrease in creatinine, an increase? Do you want to see a bump, like an increase followed by a decrease, or actually a decrease followed by an increase, or would you be happy to see any change in serum creatinine?
Thank you, Kevin. While the answers are coming, can you just indicate or tell us how would you measure or when would you measure creatinine during the hospital stay? Would you do it daily? How would you prescribe creatinine measurement?
Well, it's not entirely similar to evaluating diuretic response, but if you want to answer this question correctly, you need to at least have some indication of how creatinine changes. So we advise at least once daily. Of course, if you have very large, especially unsuspected change in creatinine, especially elevations, you could even argue that you could evaluate the change twice daily. But normally once daily is okay, and definitely evaluate creatinine at the day of discharge. So when you see the patient after discharge, you know what kind of creatinine he was discharged with.
The majority of the people listening to us voted for C. Then at the question, what would you expect? They say, I would expect an increase that would be followed by a decrease.
Yeah. Okay, let's build on that and see what the data say and what actually this means for a certain patient. I think that I will show you that any change is observed, and in the coming slides you'll see that probably creatinine is not the target of our therapy. So if you look at all patients with heart failure and you plot the change in creatinine, which is the left part of the figure, you see that over the time course of 7 days in hospital, you see a slight increase in creatinine. So this is the whole population. So this is the mean change. The lines that go off at each day are patients that are discharged home, where you see even a more steep increase in creatinine, perhaps suggesting that these patients were all still congested or treated differently at least. Of course, this is the mean change in population. If you go into detail in what kind of trajectories you could have, there are many different kind of changes in creatinine that you can have. And if you look at the percentages, they vary from very few. In the bottom, you have 3% where creatinine is absolutely stable, to about 15 to 20%, which is typical for any change. And this just gives you an overview of the incidence of these changes, what you can expect for a certain patient. And I can tell you, to say beforehand in a patient what kind of change in creatinine he or she will have is absolutely impossible. So let's go back to the case. We continue to bumetanide 5 milligrams to day 2. He's still mildly symptomatic, but he has peed about 6 liters, and his urinary sodium at that point is 123 still. He still has some edema in the ankles and some rales, so he's slightly congested. His lab, you see a decrease in potassium, sodium is slightly increased, and now you see that creatinine, serum creatinine, has increased by about 0.4 milligrams per deciliter. That's 40%. You also see that NT-pro is starting to decrease, but this would be called in the literature worsening renal function. You see a definite increase in creatinine. So what is true about the below mentioned statements? This bump, this increase in serum creatinine, which we will be calling worsening renal function, is A, strongly related to worse clinical outcome, B, should always be seen in the context of diuretic response, C, it occurs in about half of our patients with acute heart failure, or D, the cause is an interaction between the bumetanide and the ACE inhibitor therapy.
Okay, we also are waiting for the answer. Is it very frequent in your experience to see those changes in creatinine? Do you think it's really something that the resident and the fellow will come frequently to ask you, say, oh, what should I do? Or do you see other things that are more frequent?
Well, definitely people worry about the change in creatinine. I think that's what is clinical practice, and I hope we will be showing in the next slides that probably you shouldn't worry about too much about it. It depends where you put the line. If you have some change in creatinine, that occurs a lot. If you have very severe increase in creatinine, that occurs almost never. Depends on the hemodynamics, I guess, of the patient as well.
Then our listener were thinking that C is the 45%, but B is not far away. It's close to 40%. Then
right.
Between B and C, we have almost all the listener.
Okay. So, I think that's fairly good reasoning there. I think that 50% is probably a little bit too high. Again, that depends on the definition, but it's very good that everybody's saying that the 40% is saying that you should be seeing the change in creatinine in the context of diuretic response. And I'll show you why this is the case. Going back, if you look at the definition, what's been used in the literature, we think that a significant increase in serum creatinine, worsening renal function, occurs in about a quarter of patients. I want to remind the listeners that in a similar proportion, you also see a decrease in serum creatinine. And if these definitions are based on creatinine about 0.3 milligrams per deciliter and 25% increase, or a change in eGFR of about 20 to 25. And if you look at the data that's been presented now the last 10 years, if you group everything and do not take into account diuretic response, yes, there is an association with worse outcomes if creatinine increases, which is an odds ratio of about 1.8. But this is despite sending a patient home congested, having a good diuretic response, sending them on or off neuronal blockade. So this is just the general thinking. What actually happens, and this is data on the left side from Testani, showing you with the blue line where creatinine is stable over hospitalization, that the prognosis is much better than when the increase or decrease in creatinine occurs. So there's not only a worsening of creatinine, but also, if you want to speak of it, an improvement in creatinine. So it's much more than just the number creatinine. On the right side, you see that the data from Marco Mitra group showing you that the upper line, which is the green line, those are the patients who only have an increase in serum creatinine, while the patients on the red line are those who sent home with worsening renal function and residual congestion. So this tells you that probably serum creatinine is not the target to treat, but it's congestion. So last question for this case. I'll remind you the patient is on bumetanide 5 milligrams. He's mildly symptomatic. He has some edema, rales, and he has quite good diuresis in the first 2 days, but his creatinine has bumped 0.4 milligrams per deciliter, worsening renal function. What will your next step be with diuretic therapy? Will you continue it in the same dose? Will you increase, decrease the dose, or will you stop the loop diuretic altogether given the change in creatinine?
Yeah, this question, Kevin, is an important question because it touches the item of safety of diuretics. I think by answering this question, you will help us understanding. Wow, then A got 50% and C got 30-ish%.
Right. Okay, again, I think that's a very good response. I think that you could argue that the creatinine did increase to a substantial amount, but again, the patient is still congested. You have a therapy that works, you give 5 milligrams of bumetanide, he's still congested, creatinine increased, but I just showed you that this doesn't happen, this doesn't hamper prognosis, diuretic response is good. So we continued the same dosage, and then after 3 days we re-evaluated. He peed another 2.5 liters, symptoms improved further, no rales anymore, and important to realize, during the change in serum creatinine, we kept him on the same doses and the same therapy of evidence-based therapy. So on ACE inhibitor and on beta blocker, that like we just discussed. Potassium is slightly lower even, so sodium is 145, and look at creatinine now, you see that it increases even further. So you do have a good diuretic response, but creatinine increases a little bit further. So if you want to summarize what we've just seen in this patient, I want to run you through this graph. It's slightly difficult, but I hope you can follow me. On the x-axis, you see the clinical context. So this is, if you will, diuretic response. How does the patient do based on your therapy? So on the left side, you see the red square where the clinical context is a deterioration, where the prognosis is poor. On the right side, you see the improvement in clinical contact, which happens more often, and prognosis is better. And on the y-axis, you see the changes in renal function assessment. So this is creatinine, eGFR, or urine output. And you can see it in the top of the pyramid, you have acute kidney injury, probably happens very rarely in patients with acute heart failure, then worsening renal function, which is much less severe, and you see the pseudo worsening renal function, which means that yes, change in creatinine occurred, but this was in the context of an improvement of clinical signs and symptoms and diuretic response. So if we plot our patient in this graph, I think it's very easy to do. He started off with the first red dot, he was an improvement in diuretic response, creatinine didn't change, and then you saw in day 2 and 3 that creatinine increased, but still there was an improvement in diuretic response. And if you now continue the same dose, it's very likely that he will go further along the top of the pyramid. That's something you should prevent. So why actually does worsening renal function occur? We don't entirely know this. We do know that there is an association between persistently increased central venous pressure, and worsening heart failure. What we also do know is that by giving diuretics, we do have some intravascular depletion, and because there's not enough replenishment from the interstitium, you can have a change in intraglomerular hemodynamics, which are the main driver of GFR in patients with heart failure. What we definitely do not know is whether or not loop diuretics cause direct effects on the GFR and the kidney themselves in the acute phase. This is data from Wilfried showing you that higher central venous pressure in the lower part of the figure is definitely associated with more worsening renal function altogether, so not taking into account diuretic response. And you can also see on the right side that even after 72 and 96 hours, severely increased central venous pressure was associated with worse outcomes, with more worsening renal function. So what happened with this case? He was almost euvolemic, not entirely on target weight, but we had to down titrate bumetanide. I think that's reasonable given the change in creatinine, then to oral, and we continued and tried to up titrate these evidence-based therapies. You see the changes in the lab values, and NT-pro, as you can see in the graph as well, will change to below 500. And you can see in 14 days when the patient was re-evaluated, you see that creatinine changed to almost the same level as before admission, and NT-pro was still slightly elevated again. So summarizing what I just told you, that if you have a patient who has an increase in serum creatinine, you can go either way. You can have a patient who has a good diuretic response, perhaps by the algorithm we propose. You can have a good diuresis, a good natriuresis. Then you can leave the creatinine alone, so to say. You can titrate diuretic based on congestion and try to decongest the patient. Of course, you still need to re-evaluate kidney function, creatinine and electrolytes, especially potassium, but especially the patient who have worsening renal function and deterioration in clinical status, who have a poor diuretic response. You should think of why does this happen. Is the patient, does he have deterioration of hemodynamics? Is he still congested? And you should not refrain from intensifying diuretic therapy if the patient is still persistently congested. And of course, in this case, you definitely need to reevaluate renal function and electrolytes. So coming to the take home from this case, I think we both showed you that diuretics are inevitable in acute heart failure, and you have to dose them adequately, not only at admission but also afterwards. The increase in serum creatinine occurs about 20-30% of patients with acute heart failure, but this is not a problem if diuretic response is favorable. So it's not a reason by itself to stop or down titrate diuretic therapy. So you should target diuretic response and decongestion, not only renal function. Of course, when renal function increases to substantial measurements, then you should evaluate the reason for this. And both Wilfried and I have made a case that you should continue, restart, or even up titrate evidence-based therapies during hospitalization.
Thank you, Kevin. We have a lot of questions for both of you, but many to Kevin. I would start, if you agree, with maybe short questions and if you can give short answers. Many of our listeners said, but you did not, both of you did not talk about body weight. It's taught in the medical school that the patient should have a body weight at admission, at discharge. When they're an outpatient, diuretics is managed based on body weight. How would you place body weight in the algorithm and all what we discussed?
Body weight is very difficult. We know that body weight only changes only the day before or something like that, admission. And during admission, getting the first weight when the patient is admitted is very difficult. Changes in weight are not always the same as changes in volume. Changes in weight do not reflect natriuresis. I think it's inevitable, and I think it's a good idea to monitor weight, especially at the day of discharge. I think that's good. That gives you an indication of where the patient is going, but it's in no way the same assessment of volume as having volume diuresis or natriuresis. Perhaps.
Plus, to come back to what Wilfried is saying, first sodium and urine output, and then body weight, maybe a longer time.
Exactly. Yeah.
Yeah. Would you agree? Okay, Kevin. several questions, I would say, from UK. Bolus versus continuous. Are there data to say that one is better than the other based on the algorithm we discussed earlier?
Well, we only know from
And I'm sorry, somewhere even saying in kidney dysfunction patients. I mean, in CKD, or are there data to say one is better than the other?
Well, and let's stick with at least heart failure with or without renal dysfunction. The only good trial, the only trial to assess it was those. Continuous versus bolus didn't matter, but those did not use bolus before continuous. And I think it's important, that's why I emphasize it so much, that if you give continuous, and there could be a reason to, could be logistics, then you definitely have to give a bolus of diuretic. Coming back to back to our algorithm, this of course is a case before we put forward the algorithm. It's important that you need to re-evaluate diuresis, natural uresis, so in this case, starting with just a bolus, waiting for the diuretic response, and then basing your therapy upon that, on our algorithm, would be the way forward, I guess.
Several questions on ACE inhibitor and worsening in renal function. Then several of our listeners said, okay, I agree, I increase the dose, I see creatinine is increasing, but the patient is going to leave the hospital and he's under a certain dose of ACE inhibitor, and what should I do? I mean, some are saying I would stop because I'm afraid by this increase in creatinine. What would you advise me to do?
I hope I made a case that the change in creatinine is definitely not because of the ACE inhibitor. Actually, there's what Wilfried touched upon again, is that you should try to keep them on an ACE inhibitor or even up-titrate them if creatinine permits this, because this would allow you to down-titrate diuretics. The patient will be longer term out of the hospital. Of course, there are limits. If creatinine comes to 2, 3, 4, 5, and you have no options, is hypotensive, yes, you still need to do something with an ACE inhibitor. But if there's a patient like this, who is hypertensive, just has a bump in creatinine because of his decongestive therapy in the end, and he is being decongested, then keep them on an ACE inhibitor as much as possible. We cannot emphasize as much as this.
Then to summarize what we said earlier, we keep him under ACE inhibitor, beta blocker. And we have him being watched within the next week. Check again the creatinine and see whether he's in the right direction.
I think we also have to add the potassium, of course, there. If the potassium is going up and goes to 6, that would be the point that you would probably going to reduce the ACE. It's more than just the serum creatinine. That's what Kevin and the algorithm will allude to.
We have a question then following what you said is, okay, then creatinine is increasing, we keep the medications, and after 1 or 2 weeks creatinine is still high, and one of our listeners is saying, but when would you send the patient to a nephrologist? Is there one stage where you think really the patient is doing organic injury, or how would you play it?
It's difficult. I mean, in general, if the patient has not a lot of comorbidities like long-standing hypertension, like severe hypertension, diabetic, those kind of patients who could have intrinsic kidney damage, I would say that most of the renal dysfunction in heart failure is hemodynamic, or could be the use of diuretics or those kind of regimens. I think if you're unsure about the diagnosis that it is related to the heart failure severity, I think you should talk to a nephrologist, ask him or her whether or not she can contribute something. But in the end, it is just the organ that is distal to the heart, and it's probably an effect of the heart itself. But of course, it's always good to have a close, a short line with your nephrologist to discuss these kind of patients, although in my experience, they are not that frequent.
Wilfried, maybe you can take that question. There's one of our colleagues who said, I like the algorithm, I'm ready to do it, but the whole algorithm was not validated, although some pieces were validated. Mm-hmm. Is it enough for us to use it and even to promote it in our national level?
Yeah, we strongly feel it is. I mean, the data are really supported by a lot of evidence. It's also that we put forward that you have to measure natriuresis only the first 24 hours. We have a lot of data suggesting that it's the way to move things forward. So I think it is. The algorithm has also been endorsed by ESC. So we really feel this is the way to move things forward. Yes.
Several questions on SGLT2. Diabetic patients now are receiving those drugs. Those drugs are then inhibiting the reabsorption of glucose. There are diuretics, at least the urine output is increasing. Then we have questions coming, asking what should, is the line of thought the same? Mm-hmm. Is sodium in the urine different? How should we manage the patients who are under SGLT2?
Take that? Yeah.
Yeah, so actually we do not know in detail because we haven't done large trials in acute heart failure. Those patients who are on ST2 inhibitors because they are diabetics or diabetics with heart failure, yes, I think you should continue them on the therapy because they seem to be life-saving in diabetics. If you switch it around, the patient who has heart failure and has diabetes, those trials are running. Of course, we still don't know how they're going to fare within the acute heart failure. We still have to do the trial. Yes, they have diuretic properties. Perhaps we should point this way. This is my take on it. Just try to continue them because they're life-saving in diabetics. Whether or not in primary heart failure patients, we should do the same. I think we need to await further trials.
Okay. You mentioned earlier, Wilfried, about potassium. Mm-hmm. Then here we have few questions about spironolactone, potassium, Lasix, again, in the transition between the patient is in the hospital, he's going to leave the hospital. We said earlier that we should see him, the very congestive where we had to increase the dose, we should see him within 1 week, either us or the GP. We should check creatinine, but here the question is, okay, but potassium, spironolactone, how should I play with that?
Yeah, so first of all, spironolactone is not considered a lot of a diuretic drug. So in the algorithm, we didn't put it as a first-line agent. We only put it when you had the maximum dose of the loop diuretics. But spironolactone is a class 1 recommended drug if you have HFrEF.
Absolutely.
So your patient cannot go home without spironolactone if he has been admitted with acute heart failure. But of course, you have to watch the potassium. We all know that. So if your patient has a potassium of 3.5 when he leaves the hospital, there is clearly room for spironolactone. If your potassium is like 6, then that would be the moment to down titrate to spironolactone.
Wilfried, I'm going to ask you to promote a little bit HFA. Mm-hmm. We got few questions on where can I find the algorithm. Can you say again where this algorithm was published?
The algorithm was published in the European Journal of Heart Failure, January the 1st of 2019. So you can find it there.
It's the first issue of 2019 in the European Journal.
It's freely accessible by everybody. You don't have to pay for it.
Okay, perfect. Some questions again on the high dose. Maybe one of the last questions. Then you said earlier we should really, both of you, we should increase, if needed, in some patients, we should really increase the dose of loop diuretics. And then our colleagues are asking, but when should I combine with another diuretic? Should I wait for the loop diuretics to go on, or should I start the combination as early as possible? Wilfried, would you like to take that question?
I think we only have data for the loop diuretics, so we really are in favor to go to the maximum dose of the loop diuretics, which is 10 to 50 milligrams of bumetanide a day, or 400 to 600 milligrams of furosemide a day, and then add another drug, and not add the other drug before you have the maximum dose.
Kevin, I think you have the right for the final words.
Well, no, but I totally agree. I think you need to pursue decongestion, good diuretic response, and you do this by first increasing loop diuretics, then think of new other therapies, and that probably in the future will come.
Okay. Thank you very much. We are now approaching the end of this webinar. Again, thank you so much. I would like to close this session by summarizing the key messages that we heard from our key opinion leader, and this will help our daily practice. We heard that diuretics use can be optimized and sometimes should be optimized. We advise an early assessment of diuretic effect. I think this is now rather clear, and I heard stent, I heard vasodilators. We should use as a stepwise approach diuretics and achieve a sufficient diuretic response. And worsening renal function is not a reason to withhold diuretics, but we also heard it's not a reason to withhold neither beta blocker nor ACE inhibitors. And thank you very much to Professor Wilfried Mullens. Thank you for Dr. Kevin Daman for their presentation. I would like to invite you, all of you, to the very large, the best, the more attended heart failure meeting. This is the meeting of the Heart Failure Association in Athens from the 25th to the 28th of May. We will be happy to see you there, and there will be many sessions on diuretics. You will be able to watch this webinar on demand on the ESC website. Thank you very much.